across the borders. Today we've got a very interesting specialty of rheumatology, which always puts us in dilemmas in place. And we've got two very exquisite speakers and learned people from across the borders who we will introduce in the next few minutes. Without any delay, I invite Professor Yogesh Parekh, who's the Honorary General Secretary of IAP, to inaugurate today's scientific proceedings. Dr. Yogesh.
Yeah, thank you, dear Dr. Biwan and respected seniors, dear colleagues. Greetings from the Indian Academy of Pediatrics. It is my distinct pleasure to welcome all of you. This is third session of the INDO-UK IAP webinar series, and that initiative that continues to strengthen our pediatric academics bridge across the border with the help of our Dr. Biwan, Dr. Anand, and the whole team of IAP UK branch, and it depends our collective understanding of the pediatric care. So today's topic, not all joint pain in GIA. Not all GIA has joint pain, is a powerful reminder of all the diagnostic nuisance we face in our pediatric rheumatology. And it challenges us to look beyond the textbook definitions and embrace the complexity of the real world clinical presentation. And for this, we have a two honored distinguished expert with us, one from the UK, Dr. Kishore Warrior, whose insights into atypical presentation will sharpen our diagnostic acumen, and our own Indian respected Dr. Sujata Sahan Madam, a leading voice in the pediatric rheumatology, whose experience in the UK and the India and at global level will eliminate the subtle signs we must not overlook. And our moderator, Dr. Anand, she was the very active member of the UK branch, bring his own wealth of the expertise to guide today's discussion and ensure a dynamic and rich exchange of today's program. So as a IAP, we remain very committed to fostering such collaboration that elevate pediatric practice and empower clinicians with the latest knowledge. I thank our UK partners for their continued support and enthusiasm in this shared journey. Let us engage, learn and grow together, because every child deserves the best we can offer. So at this moment, I welcome all of you, Dr. Biwan, Dr. Sujata Madam, Dr. Anand, Dr. Kishore, Dr. Hemant, Dr. Ramesh Bajenia sir, Dr. Atanu Badra, and today our President, Dr. Vasant Khalarkar, is flying back to the India, and our beloved President, Dr. Basavaraj, is also joined now. So we welcome all of you to this today's Indo-UK webinar series 3. Thank you very much for joining, and I welcome all the delegates and our senior experts. Dr. S. Srinivasan sir also joined. So whole senior to all the experts here. Thank you very much for joining all of you, and over to you, Biwan.
Thank you, Yogesh. I have got my beloved ex-president, and my beloved friend, Dr. Basavaraj, who is again a fountain of knowledge and dynamics. He has joined, I can see. So Basavaraj, if you can say a few words, please.
Yeah, thank you very much, Dr. Bihan, taking in Indo-UK CME in a meaningful way, which is making a lot of difference to the Indian context and as well as to the others too, whatever the feedback we got it. And the academic things which is reaching in a greater heights. I'm sure today's deliberation, which is going to be moderated by none other than Dr. Anand Srivatsa, who has been very, very instrumental in bringing the academic things between the India and UK, and within the great stalwarts in the field of rheumatology, Dr. Sujata Madam, Dr. Kishore sir is here. I am sure today's deliberation, which is going to make a big difference to all the participation. And of course, with the presence of our President-elect, Dr. Neelam Mohanji, and Dynamic Secretary, Dr. Yogesh Parikh ji, and Ramesh Bajania, Dr. Atanu Badra, all who have been working to take all the academic events to the greater heights. Best wishes for today's program. Thank you.
Yeah. Beyond Dr.
Thank you.
Neelam, Madam joined now.
Yes, yes. Hi, thanks, Vasav, Dr. Vasav, and we've got our ever dynamic and upcoming president who has just joined us, Dr. Neelam. If you can say a few words to highlight this event.
Thank you, everyone, and it's indeed a pleasure to be on this platform. What a wonderful name, Indo-UK. We used to always be very excited when there used to be matches between India and UK. And here you go, IAP is no more behind. IAP wants the collaboration with the UK team, because when you talk about structured way of approach, and when you talk about ensuring that everybody gets the same quality of care. In that, I would wink not twice to say that UK always takes the lead, because through the NHS system, they have always believed in ensuring that the quality of teaching, the quality of care is practically the same in all. So that is something very good that we've been seeing. But at the same time, the USP of India is that the Indian doctors are always bright, as all of you all from India and UK too, as the backbone of UK. Uh, the strength of it is that the patient get the advantage of going to the private sector, to going to the super specialist. They don't have to wait for ages like the UK. So there is something for both to learn from each other. UK is teaching us that there is a basic system which everybody should get in terms of uniformity, and India has to teach that there should not be so much of waiting when it comes to speciality. And here we have 2/3 of our practice comes from the private care, and the government through its Ayushman is expanding to give again the care. With that, a few words that I had to talk about India and UK. I'm so happy that we have Bivan coordinating from there, beloved Yogesh, who is extremely, coming from the state of Gandhiji. He wants an extremely righteous person, tries to do, and that's the connect with me, because he reminds me the basic tips that I was taught by my father. And Raja, as the name indicates, is totally a Raja who rules over the hearts and of many of us in India. And with the two people that I'm seeing who are coordinating, Anandji from there, as well as Sujata, I had the fortune to work with Sujata together. Both of us were in Gangaram, a lady who was extremely caring for her patients. She would go out of the way to ensure, and if I have to talk about empathy that a doctor should have, Sujata was one of the top runners in my mind. During my early years of practice, what I learned from her was empathy, and some common which we would probably share, if not the same subject. And we look forward for more and more series of the Indo-UK. And third is always special. So today is the third series. And wishing you all the best for a rocking show and many more to come under the able leadership of IAP, which is coordinating and collaborating with UK. Thanks to our predecessors, including Baswaraja and the others who took this step to ensure that Indians all over come together, share their knowledge, and ultimately improve the care of children worldwide, globally, and all should benefit in that. We all have something to exchange and learn from each other. Thank you for having me.
Thank you, Neelam. Thanks for that excellent inspirational talk. Just wanted to say that Indo-UK are in the same team this time. We are not playing any matches. We are in the same team. So just before, last but not the least, I have got Dr. Atanu Bhadra, who's like my elder brother. I think he has got something to say and a bit of a warm welcome for the upcoming Pedicon as well. So Atanuda, if you are still around, I'd like you to say
He's
a few
here. He joined.
Yeah. Yeah. So I think this is the result, the fruits of the inputs of many persons that we are having the Indo-UK webinar series continuing under Beyond the Borders. I think our past president, Ramesh sir, Dr. Santosh Soms, Dr. Basav sir as secretary initially and then as president, and Dr. Vasant sir, and of course Dr. Neelam and Dr. Jogesh all have contributed to this Beyond the Borders, because when we started B1, if you remember, that it was a very uphill task of trying to get into it. But we are really happy that this has borne fruits and we are having this series going on. And of course, welcoming all the UK team to Calcutta Pedicon in 26 January on behalf of Dr. Neelam Mohan and all the others, our president, who will be taking charge from that point onwards. So please come. We are there to welcome you. Thank you. Over to Bivan.
Thank you, Atanuda. Thank you. And yes, Pedicon 26 will be something to remember, I'm sure. With that, I hand you over to the moderator and host for the evening, Dr. Anand, who is our scientific coordinator for IAP UK. Anand is a consultant pediatrician in Nottingham, and has got an interest in allergy. And he's a very dynamic person, has helped us in organizing these three webinars. We do it every quarterly. And he is going to introduce you to the speakers and how the system will run. Over to you, Anand.
Thank you, Bevan, and a warm welcome to all of you, seniors, colleagues, and the IAP team. So I think we want to do it in an hour's time, but I think I'll give 10 more minutes for question answer as extra. Hopefully, people will stay on. So let me introduce, without taking more time, let me introduce you to Kishore and Dr. Sani. So Kishore Chandran Warrior is obviously from Kerala, and he studied in Thrissur Medical College and did his other degrees in pediatrics from Calicut. And then he moved to England and completed his training from Newcastle University Hospital. And then later on, he joined, I will say, as my senior in 2013 in Nottingham. I was amazed by this fountain of knowledge in front of me, who knew everything about anything. And believe me, when I had any difficulty in any of the patients, irrespective of rheumatology, I just went to him and we got the answer. So that's his introduction in short. He currently is chief investigator and principal investigator of number of commercial and non-commercial clinical trials. He is chair of UK Juvenile Dermatomyositis Research Group, and he's also a member of Clinical Affairs Committee, British Society for Rheumatology. And he will be doing his presentation today on juvenile idiopathic arthritis. And let me take a quick look at Dr. Sujata Sahni. I heard great things from Kishore about her. And she is a senior consultant pediatric rheumatology at Institute of Child Health, Sir Gangaram Hospital in Delhi. She is a past president of Pediatric Rheumatology Society of India. She's member editorial board Pediatric Rheumatology Online Journal, and presently involved in teaching of pediatric rheumatology fellows at Gangaram for last 14 years. She has also qualified from UK and after doing her MD in pediatrics, and she also holds a certificate from Australia about pediatric rheumatology. Her research interests include MSK, US ultrasound in pediatrics and childhood lupus and uveitis. She has published a very well read book on pediatric rheumatology, A Clinical Viewpoint, with Professor Amita Agrawal. So we look forward to her comments on the talk today, because obviously Kishore and they should be leading. I'm just doing the general pediatrician's role here because JIA can be the most complex diagnosis or presentation, I should say, you can come across. And that needs some real clever people to sort out this issue of differential diagnosis and getting the diagnosis. So over to you, Kishore, for your presentation. Thank you.
Thank you very much, Anand, for the kind introduction. First of all, big thanks to IAP India and IAP UK for having me, giving me the honor of doing this talk. I still remember in 2005 when I left the shores of Thrissur, I was the joint secretary of the local IAP, and I had an honor of returning to IAP Thrissur to present a lecture about a month back. So I'm still greatly indebted to IAP for my development, and thank you for the opportunity. And it's a great honor to share stage with Sujata Madam, who is very well known name in pediatric rheumatology in India, and she has authored the textbook along with Amita Madam, one of the most respected ped room textbooks we have, not just in India but even outside. So it's a great honor, and thank you very much. So shall I share my slides if that's okay?
Yeah.
Can you see my slides now?
Yeah.
And is it moving, Anand?
Yeah. Full screen. Yeah.
That's brilliant. Thank you very much. So without any further delay, I'll go to my topic, which is revisiting GIA or giving an update on GIA. And the roadmap for today, I think I'm talking about pediatric arthritis in general and the diagnosis of GIA. And I would like to reiterate that the focus is on diagnosis and differential diagnosis rather than the therapeutics, which is probably a more complex discussion for a pediatric rheumatologist. So the disclaimer, as I said, the focus is on diagnosis, not treatment. Now, I'm a practicing rheumatologist in a different, covering a different population in a different healthcare system where the pathways of care are different and checks and control are different. So there may be subtle differences in how the practice is in the two countries. And obviously, I have close contact with Indian scene where pediatric rheumatology is very vibrant now with a lot of fellowship schemes and a lot of new young pediatric rheumatologists in the scheme industry. So just to reiterate, GIA, juvenile means onset before the 16th birthday. Idiopathic means we don't know the cause or we need to rule out other cause. We all know that it's actually wrong because we all know it is autoimmune. But because we don't have a pathognomonic autoantibody like we have in lupus, we still call it idiopathic. I think it's high time that, like ITP, we move from idiopathic thrombocytopenia to immune thrombocytopenia. I think it's a matter of time before GIA moves on to juvenile immune arthritis rather than idiopathic. And arthritis means inflammation of joints. That should have gone on for at least 6 weeks, for which we've not been able to find any other cause. Now, why did we choose 6 weeks? It's probably a number plucked out of thin air, but the fact is we would like to rule out a lot of reactive arthritis. Otherwise, we'll be overtreating these patients with immunosuppressants. So a quick recap. As a pediatrician, as a practicing clinician, it's important to distinguish between arthralgia, which is pain, and arthritis, which is inflammation. And obviously, I'm sure you all know how to distinguish, which is we look for signs of inflammation, swelling. There's history of stiffness, especially in the morning. The joints are usually hot or warm to touch. They can be restricted in both conditions, even in chronic pain, for example, you can have restricted joints. So that itself is not a telltale evidence. And the symptoms are generally worse at the beginning of the day. They are stiff in the morning and symptoms improve as the day goes. Whereas in chronic pain, it's often, or mechanical pain, it's often related to activities and it gets worse. The next important question is how long have you had the problem for? Sometimes patients come to me saying that I've had knee pain for 4 years. And we know instantly that this is not GIA because had it been inflammatory, it would have progressed by then. Whereas we need at least 6 weeks to make a diagnosis of GIA. The next question is how many joints are involved? The diagnosis becomes even more tricky if it's a monoarthritis. I'm sure we all recognize the importance of ruling out septic arthritis in these patients. Again, the common joints involved are knees and ankles. But again, when I get an isolated hip arthritis, I get very concerned about whether am I missing something else? Is this an infection, or is this even something else like a malignancy that has caused a reactive effusion? So we need to be cautious. Polyarthritis, we know the chances of that being JIA is much more, especially if it affects the small joints. But even from the pattern, we may be able to recognize that diagnosed, for example, if the patient has called dactylitis, which is the inflammation of the whole digit or swelling of the whole digit, that may point to a diagnosis of psoriatic JIA and not just any other JIA. People often forget about back, and it's important that we always ask about spine, neck, and jaw. And it's very important because early jaw involvement is important because we need to pick that up early and escalate treatment so that they don't end up with erosive jaw disease that may lead TMJ replacement as we go along. Again, there are things which are not quite joints, but may give you clues like dactylitis and enthesitis, which is basically inflammation of the points where the tendon enters or joins the bone. Now, what are the systemic symptoms we would look for? Obviously, from an infection point of view or from a malignancy point of view, we need to think about fever. It could also be systemic onset GIA. Rashes are very important. I always feel that skin is the mirror to the joint disease. So and it's important to ask for rashes. And if the patient is very unwell and toxic, again, I would really want to make sure that I rule out infection or neoplasia before I give any steroids at these patients. These patients may experience eye symptoms because of uveitis, and especially if it's enthesitis-related arthritis, that is HLA-B27 positive, they often get a painful red eye. GI symptoms are important because this arthritis might be because of HSP, or it could be because of inflammatory bowel disease. Again, loss of appetite and loss of weight would make me worry about IBD or malignancies. Often, joint swelling or arthritis can be the presentation of connective tissue diseases. It could be mixed connective tissue disease, it could be lupus, etc. So it's important to ask for symptoms like rashes, mouth ulcers, hair loss, Raynaud's, because if the patient has got a rapid or recent onset Raynaud's, and that can actually suggest that this could be a lupus and something else. Then cardiopulmonary symptoms again should make one suspect connective tissue disease than JIA. And sometimes the history of preceding infection may be helpful, but this could be nothing but a post-streptococcal reactive arthritis, which has kind of gone on for slightly longer. Of course, the rest of the history is important too. Steroid history is important because if the patient has had prior steroids for whatever reason, that can alter the course of arthritis. Travel abroad is important for people for like us, because I recently had a patient who had gone to India, got salmonellosis, enteric fever, and she came back and had a reactive arthritis affecting two knees. So the history of travel abroad or forest trails are important because it can be borreliosis that can present with arthritis. Sometimes the development may be a bit tricky because you can say that mom may say that this is a 17-month-old girl who had started walking and now has stopped walking. And the developmental regression is purely gross motor, and that's probably reflective of the arthritis. Family history is helpful, but not kind of definitive. If there is a strong family history of autoimmune conditions, that is one thing that should make us suspect GI a bit more. And then obviously these joint problems can have an impact on their social life and especially physical activities. Examination wise, obviously we would start off with vital signs. Rashes are very important. I'll just take you through a few rashes. So this young lady here, you can see a salmon colored pink rash over the trunk. And the story is that that comes on with fever and gets worse when she scratches it. And it goes away when the fever goes. This is a classical Still's rash. Again, this young boy has the same thing, and you can see the axillary lymphadenopathy with that. The bottom, we have the HSP rash, I'm sure you all know. And this young lady has a classical lupus rash and has presented with polyarthritis. Similarly, important of examining scalp and nails. Scalp is very important, even though the patient may be treated as seborrheic dermatitis or something, it might be actually a presentation of psoriasis. And similarly, nails, pitting of nails or very fragile nails that break up easily may suggest psoriatic arthritis. And sometimes you may have nail fold capillary changes, which suggest that this is a joint pain in a patient who has got an underlying connective tissue disease like dermatomyositis or lupus for that matter. Again, this serpentinous rash is what we used to get as a part of erythema marginatum in patients with rheumatic fever, which we don't see these often these days at all. Erythema nodosum, this could happen in patients with IBD arthritis, post-streptococcal, or even sarcoidosis, which is not that common in children. And this is a classical erythema chronicum migrans, where you have that in the tick bite in the middle, surrounded by a spreading area of erythema to suggest an erythema chronicum migrans. Again, eyes are important. Sometimes you may see a festooned pupil because of synechia, because of uveitis. ENT examination again is important. And then we look for pallor, generalized lymphadenopathy, things that may suggest a malignancy. Subcutaneous nodules are very rare these days because rheumatic fever is rare. And if you see a patient who has got easy bruising or anything to suggest low platelets, then we need to again think about malignancy. And examination, obviously, we need to have a detailed examination of the joint where we look for warmth, range of movements, and muscle wasting, which kind of tells us that this is a chronic, long-standing effusion, not a short effusion. And I'm sure we all know about PGALs, which is a very good screening tool to look at other joints. But it's always important that we don't forget to examine the jaw, spine, and sacroiliac joints in these patients. The history for sacroiliac joints can be vague, and sometimes they may present with a story of buttock pain. So a patient with arthritis complains of buttock pain, always think about sacroiliitis. And obviously we round off the examination by examining other systems. Now, this is a classical presentation of dactylitis where the swelling is not just confined to the joint, but to the whole digit. This young man came to us some time back with an arthritis, but he didn't have any psoriasis at the time, but he had dactylitis, and as you can see, he had really bad nails, and that was enough to call him psoriatic GIA. And similarly, this young lady has got swollen enthesis pressure points here. Now, how do we assess enthesitis? Depending on what system you use, you could have anywhere from 6 or 18 sites to examine. This is my practical tip. I would look for the lateral epicondyle of the elbow, anterior superior iliac spine of the hip, and I would look for the inferior and superior pole of patella in the knee. I would look for Achilles tendon and plantar fascia. So if these 6 sites are normal, it is highly unlikely that the patient has got enthesitis. Obviously, as you can see in the picture, there are more enthesitis sites if you want to give a complete examination. But this is what I use in my day-to-day practice. Investigations, it's important to remember that JIA is a diagnosis, or it's a clinical diagnosis. It's not a laboratory diagnosis, but some of these parameters may be helpful. A blood film is important to rule out leukemia, especially if the full blood count shows low platelets or low white cells. ESR and CRP are usually raised, but not always. Infection screening has got limited role, but however, if you are suspecting a reactive arthritis, you may want to do an ASO titer or some limited viral serology. Autoantibodies and rheumatoid factor, again, if they come back as positive, they may be helpful. If negative autoantibody screen does not help anyone. I'll come to that in detail a little bit. Ferritin is an extremely important tool to diagnose systemic onset JIA. So if the patient has got high fever, especially quotidian pattern with rash and joint pain, ferritin is the one which is likely to clinch it, especially if that patient is going on to macrophage activation syndrome, which is the most dreaded complication. The imaging is not routinely done, but we may need to help of imaging to find out arthritis in deep-seated areas like hips, and it's up to us to decide whether ultrasound or MRI is the best modality depending on the site. I would always get my patients checked over by the ophthalmologist to look for uveitis if there is a suspicion of GIA. So what are the causes of polyarthritis? It could be infective. Again, if it's infective, it's more likely to be monoarthritis than polyarthritis. If it is polyarthritis, then most likely to be reactive rather than infective, as you can see as the second cause. Then sometimes it can be inflammatory, and it's important to look for think about mechanical causes, neoplasia, and rarely even metabolic diseases can present as swollen hands, which may be mistaken for GIA. A classical example is mucopolysaccharidosis, where you can get broad swollen hands, which may be mistaken for GIA. And all you need to do is a plain X-ray that can show the classical bullet-shaped metacarpals in this patient. Now, I thought it may be opportune to discuss some cases before. And Anand, if you could just remind me when I'm getting to the time, please, because I'm quite well known to get carried away. So this young lady was 11 months old and she presented with a pain in right ankle. Basically, she was refusing to weight bear and screaming on movements. So she was taken to the local AIE who they suspected irritable hips, which is transient tenosynovitis. So did an X-ray of the ankle and hips, which were normal. The patient was reassured and sent home. However, the symptoms persisted. 2 weeks later, she ends up in the pediatric admission unit where she undergoes bloods, which showed a slightly raised ESR, and the X-ray at that stage was normal. From then on, she became less well because she was getting fevers on and off. But again, all the other joints were absolutely fine. She was still happy and playing, although she would not use that ankle. She underwent an ultrasound scan as an outpatient in the local hospital, who picked up an effusion and referred her. So on examination, this was a well girl, but who refused to weight bear on the left ankle, and she had a swollen or restricted left ankle, but otherwise fine. Her ESR was 40 and the CRP was 5. So what do you think is the diagnosis here? So it is very easy to think about JIA being a monoarthritis, and people said it's not infection. But because it's 4 weeks from then, the first thing I thought would do a plain X-ray. And so we did a plain X-ray, and I was suspicious about this bit on the talus, which looks a bit translucent, and it was confirmed on the subsequent X-ray. Can you see that? The posterior bit of the talus is eroded. So this is osteomyelitis of the talus, which is causing a reactive effusion in the ankle. So this is not septic arthritis, but osteomyelitis. So what are the learning points from this case? When you have a single joint pathology, always consider infection. It is important to remember that osteomyelitis has a more insidious onset and a less aggressive course than septic arthritis. When we talked about septic arthritis, we say high fever, patient very unwell, looking toxic, but it doesn't happen with osteomyelitis. The onset is more insidious, and so is the progress. So if the osteomyelitis happen adjacent to the joint, it can always cause a reactive arthritis, giving you a feeling that this is arthritis. So what is the best imaging? If it's less than 2 weeks, we all learned that X-ray is useless to diagnose osteomyelitis. Whereas if it's more than 2 weeks, there is still some role for conventional X-ray. I'm not going to say that it's going to be diagnostic, but it might actually give us some clues. But obviously then we have to go for MRI scan to confirm that. So I had an interesting email from one of my hematology colleagues, because they had this 4-year-old, I can't remember, a boy or a girl, who is in maintenance phase of leukemia chemo, who presented with swelling of left ankle with no fever. So on examination, there was a mild fullness, but it was not warm. They said the X-ray is normal. So her question to me is the GIA? And if not, what else it could be? What do you think? My reply was that JA is highly unlikely. She's on heavy-duty immunosuppression, including methotrexate, and that should be sufficient to treat JIA. So it shouldn't be JIA. However, I was worried about infection. The biggest worry is infection. And I explained to her that chronic osteomyelitis can be very insidious and onset, and I will have a very low threshold to do an MRI and get an orthopedician to drain this patient. The second differential in my mind, because of shed loads of steroids, was avascular necrosis, which again would need an MRI scan. So this happened on a Friday. When I come back on Monday, I get this email. Thanks, Kishore. This girl spiked temperature on Saturday, came in, had osteomyelitis, orthopedic team drained it. So this is again a classical example of an insidious onset pain without much features of inflammation, which again suggests osteomyelitis, which was probably masked also by the level of immunosuppression. So this is a 12-year-old Indian boy of Indian origin who again came and saw me about 4 or 5 years back. He came presented with pain and swelling in the left knee for 1 week. The story, and then he had gone to GP and he had a very high ESR and CRP and was rightly referred to orthopedics. So they did an MRI scan. As you can see, there is a huge effusion in the MRI scan. And they aspirated and started him on IV antibiotics for septic arthritis. But after 48 hours, the cultures came back as negative, antibiotics were stopped, and he was discharged home. He was reviewed by a fracture clinic in 1 week, and our swelling had actually got worse. And at that point, they referred him to rheumatology. But the family were going on a cruise the very next day, so they forced the orthopedician to inject the joint with steroids so that he could have a pain-free trip. So this was a cruise complicating an arthritis. And then 10 days later, he finally came to rheumatology clinic. But I was a bit surprised because although he had an improvement for 48 hours, his knee was still not back to normal. And the parents said he's not the normal boy. He's got reduced appetite. He is having low energy levels, intermittent fever, etc. So his symptoms had not settled down. But they said all of the joints are fine. There was nothing else like recent trip to India or elsewhere or any forest. There is no family history of TB or anything, which is what we would suspect in a monoarthritis as well. On examination, he still had a moderate sized effusion of his left knee, but rest of the examination was fine. And at that point, I felt this is now 3 to 4 weeks from onset. This probably is JIA, but there were so few odd factors. One is he had extremely high inflammatory markers, which I would suggest, which is not that common in JIA that's presenting in only one joint. He had an incomplete response to steroid injections, and he still continues to have systemic symptoms, which makes me slightly uncomfortable. So I thought I'll repeat the blood test, including extensive infection screen for Lyme disease, TB, etc., and ASO titer. And I also referred him for uveitis screening. And the plan was, if I felt he was JIA, I would repeat the joint injection. The results showed that his inflammatory markers were better. His TB, Lyme serology, everything was negative, but he had an ASO titer of more than 1600. So by the time he came to joint injection a week later, the swelling had completely gone. And he never had any joint problems after that. So this is a classical example of post-streptococcal reactive arthritis, which we would expect to settle down within 4 weeks, but sometimes it can take slightly longer, like 8 to 12 weeks. So post-streptococcal usually follows a group A streptococcal infection. Interestingly, unlike rheumatic fever, this has got a bimodal presentation. You can get that in children with 8 to 14 years and young adults about 20 to 40 years. There is a theory that it's more in children who are HLA-B27 positive, but there are three big differences with acute rheumatic fever. It's usually symmetric involvement of large joints. It's classically non-migratory. There is no flitting and fleeting story, and these patients respond poorly to aspirin and NSAIDs. The teaching I received and what I've observed during my times in my pediatric wards in India is that the moment you start aspirin, the arthritis improves a great deal in acute rheumatic fever. It is aspirin is said melt the arthritis, but as these patients have a very less profound response, let me put it that way. There is bit debate, but I don't think there is a significant cardiac involvement risk in these patients. They have quite high inflammatory markers, and NSAIDs, they eventually respond to NSAID, although they don't respond dramatically. And all my patients with PSRA, I give them penicillin prophylaxis for 1 year, do another echo, make sure it's normal, and then stop and discharge it. That's how I manage these patients. Are we okay time-wise, Anand? So this is a girl. This is a girl who is present, 13-year-old girl who presented to me with a swollen left knee for 10 weeks. There is it came from orthopedics. She didn't have much pain at all. There was no history of trauma. They also did an MRI scan which showed no injury. The effusion was drained by orthopedic people and the culture was negative, but the effusion reaccumulated in no time. She's a very sporty girl and she was a bit irritated that it stops her from bending or straightening the knee fully. There were no concerns regarding other joints. She had no systemic symptoms whatsoever. The only story I got was that about 6 weeks prior to that, she was having long walks in the woods of Bavarian jungle in Germany for a long time. That was the only thing which was slightly odd because I asked for these long walks and going to remote forests and jungles at the time. But there was no history of any tick bites or rashes. On examination, she had a big effusion in her left knee. Rest of the joints were fine. She had no systemic features whatsoever, no rashes. Throat was normal. So I was kind of reasonably convinced this is oligo-GIA. So I referred her to for uveitis screening. I did her blood tests, but I also did a Lyme serology. And then I posted for intra-articular steroid injection the following week. But I had this surprise email from microbiology. She was strongly positive for Borrelia serology. So this was a presentation of Lyme disease without the classical rash, without the history of tick bite, which purely came from the history. So the big thing in the Lyme arthritis, the rule is not to inject steroids. So I didn't inject her steroids, but I aspirated. I took off about 130, 150 mils from her knee and gave her doxycycline, which she responded to. I did speak to the ID team as to whether I need to investigate a bit more for CNS involvement, do LP and stuff like that. They said it's absolutely fine. You don't have to do anything. And this patient had a complete response to 4 weeks of doxycycline. So this is an example of an infection presenting as oligoarticular presentation without any systemic features. So that's the importance of history in this patient. So the commonest manifestation after erythema chronicum migrans in Lyme disease is arthritis. It usually affects the commonest joint to affect is knee in 90%. And the serology is almost always positive, and these patients respond to antibiotics, and the prognosis is very good. A small patient of them end up with chronic arthritis who may need synovectomy. I'll just probably discuss this boy and before I go to the discussion on GIA. So this is a 3.5-year-old boy who presented, he's a patient who will stay with me forever, who presented during my time in Newcastle with a 3-week story of limp, fever, and so he was seen in A&E, a hip x-ray was fine and reassured and sent home. 1 week later, he presented with limp and now low backache. Now, one thing to remember is backache is extremely common in adolescents and teenagers. It is extremely uncommon in young children. So if young children under the age of, let's say, 6 or 7 come with persistent back pain, we need to take it seriously. So he was admitted to pediatrics, and they found that his hemoglobin is 8.7 and his CRP is 40, and he had a restricted right hip. So they did an ultrasound scan, which was normal, and they did an MRI scan of the spine, which was absolutely the right thing to do. But that was normal, and he got better, and he was reassured and sent home as a possible reactive arthritis. But again, 2 days later, the temperature came back up and worsening pain. He was pale, no allergy, didn't want to eat anything, was in bed all the time, and he represented to the pediatric department. At this stage, his bloods were worse. His hemoglobin had dropped further. Now his neutrophil count was 1.2. His CRP was 140, ESR was 130, and LDH was very high. That was very odd for a person with suspected arthritis. So they did a repeat ultrasound scan of his hips, which was normal. But as it turned out, the sonologist put the probe on his tummy. And what did he find? He found a mass sitting on top of the kidney, and he was referred. And what was that? Nothing but high-risk neuroblastoma. So age is important and the history is important, and back pain is very young in that age group. And if you look at the CT scan, you can see the big mass here, can't you? And actually, when we looked at the original MRI scan, can you not see that moth-eaten appearance of the pelvic bone? That was causing the hip pain, not actual hip pathology. And then when we looked at the original MRI scan, which was done for spine, there it is. But that was missed because the span was done for spine. They looked at spine, nothing else. But I won't blame the radiologist for that because that brought the story, clinical story fit in. Again, a reminder of malignancy presenting as joint pain. I probably would leave these slides and go to a discussion about JIA. And this one interesting boy. So this boy presented to pediatric team is a 12-year-old boy with 10-week history of swollen ankle. And he had some raised inflammatory markers and he was referred to as JIA. They started ibuprofen on our advice, but what was odd was that he started vomiting. So they started him on PPIs. They doubled the dose of PPI. He still had no response, and the NSAID had to be stopped, which is very unusual in a patient with GIA to have that much of gastritis. So when I saw him in clinic, I realized that he had lost 11 kilograms of weight in 8 weeks. He was pale, he had an effusion in his left knee and left ankle, and he also had tenderness over the sacroiliac joint. He didn't have any organomegaly, although he had some non-specific tenderness in the left iliac fossa. So what have we got? This is a classical presentation of IBD arthritis with that amount of weight loss and tenderness over it. So small bowel IBD may not have the classical chronic diarrhea, bleeding PR, loss of weight picture. This was predominantly small bowel IBD, and he had an MRI pelvis which confirmed sacroiliitis, and he was referred to gastro from my clinic, and he had extensive Crohn's starting from his proximal duodenum right all the way up to the ileocecal valve. So he was one of the worst Crohn's we had. This is a classical presentation of Crohn's or inflammatory bowel disease presenting as arthritis. I'll probably skip this one for want of time. So I'll go back to the original slide where we discussed JIA. I'm sure JIA is, you all know that JIA is the commonest inflammatory arthropathy in children with an incidence of anywhere from 1 to 4 in 1,000, depending on which part of the world you live. It is clearly commoner in girls, with the exception of endocytes-related arthritis, which is commoner in boys, and systemic onset, which is equal in both genders. In UK, we find that it is much less common in the Asian population when compared to the Caucasian population, which is exactly opposite in lupus, which is much more common in South Asian, Oriental, and Afro-Caribbean population when compared to the local white population. So this is a slide you would see, look at etiology for most autoimmune conditions. So JIA is seen in a person with a genetic predisposition when there is some environmental trigger or infective trigger. Now, one theory that has come up very important now is the role of microbiome. So microbiome is the genetic output of all the microbiota that occupy our gut, who are in a symbiotic relationship with an immune system. Now, when that microbiome is disturbed, for example, prolonged antibiotics in a child who has got necrotizing enterocolitis or anything like that, that symbiosis is disrupted. It's called dysbiosis. And there is evidence that that can increase the risk of autoimmune conditions, including JIA. So that is one thing which has come up big of late. There are lots of new theories which I'm not going to in detail. I'm sure you all know about the ILAR classification of JIA. Systemic onset JIA is very distinct from the other types of JIA, and we rheumatologists hope that in a few years' time it is going to be separated from this classification, because we know systemic onset JIA is more of an auto-inflammatory condition as compared to the other types of JIA, which are predominantly autoimmune. Oligoarticular, you are 4 or less joints at presentation, and polyarticular when you have 5 or more joints at presentation, and about 5 to 10% of polyarticular patients are rheumatoid factor positive, who then go on to become the adult rheumatoid. So they have the classical rheumatoid phenotype involving the small joints of hand. The other subtype is psoriatic JIA. It's important to make a diagnosis of psoriatic JIA because they are unlikely to grow out of this diagnosis. So actually, you don't need a diagnosis of psoriasis to make a diagnosis of psoriatic JIA. So if you have a patient with arthritis who have got either dactylitis or nail pitting and psoriasis in a first degree relative, that's enough for you to make a diagnosis of psoriatic JIA. About 40% of all our psoriatic JIA patients don't have psoriasis. Now, endocytes-related arthritis is more of the pediatric equivalent of the adult ANK-SPON, or ankylosing spondylosis entity, where they are HLA-B27 positive. They have a significant risk of involvement of axial skeleton, especially sacroiliac joints. It is much more common in boys. They have a high risk of acute anterior uveitis, and a family history is important in these patients as well. And there is a classification of undifferentiated arthritis, which may be a combination of any two of this. So this is a classical example of a dactylitis. The fourth digit here is almost swollen like a sausage, and that is why this can be a classical evidence of psoriatic JIA. So one thing I always ask my trainees to do is don't just rest on history. You need to ask for slides of hidden psoriasis, umbilicus, axilla, groin, sometimes scalp, sometimes genitalia, anal cleft. These are the places of hidden psoriasis. We had a young boy who was diagnosed with psoriasis, diagnosed with GIA, went on to etanercept. He was not fully controlled, and we couldn't get to the bottom of why he was this. And once then he presented with an infection, we realized that he had extensive psoriasis of his genitalia, and that had got infected. We added him biologics straight away, and adalimumab, and he got better. So it's important to look for hidden sites of psoriasis. Now I'll have a word about systemic onset JIA, which is a different entity because that has got a different set of symptoms and signs. This is the only subtype of JIA which you can diagnose without arthritis. Arthritis is not a must for you to diagnose this patient. The classical presentation is fever, high fever with daily spikes, the quotidian fever pattern like this. You get this is the temperature chart of these patients. They often have arthritis, they have a classical rash, often have lymphadenopathy and hepatosplenomegaly, and they can get serositis like pericarditis and pleuritis, and sometimes that can cause mortality and morbidity. The hallmark is uncontrolled systemic inflammation. Their ESR is often in 100, CRP often 200 to 300, but the one we should always check is ferritin, which is almost always in 4 figures in this patient. And this condition is associated with a dreaded complication of macrophage activation syndrome, which carries very high mortality and morbidity. So this is the classical systemic onset JIA rash that we discussed. So why is systemic onset important and probably not going to be declassified? Because it is a problem essentially with the innate immune system. So the innate immune system is very non-specific, has no memory, but it has got extremely high cytokine storm. Whereas adaptive immunity is much more cleverer. It's slower to respond, it's specific, and it has got immunological memory. So the problem affecting adaptive immune system leads to autoimmune conditions, and the problem affecting innate immune system leads on to autoinflammatory condition, which is why systemic onset GI is considered one of the commonest acquired autoinflammatory conditions in children. One quick slide. When do you suspect macrophage activation syndrome? Because that is going to be the killer. Because although systemic onset JIA forms only 10% of JIA, about 60 to 70% of mortality is because of systemic onset JIA, and that's purely down to macrophage activation syndrome. The most important symptom is the quotidian fever pattern changes. It becomes persistent fever. The signs of systemic inflammation on the full blood count, because these patients often have leukocytosis and thrombocytosis. Now that changes and that becomes pancytopenia. So if you have a patient who had a platelet count of 800 that fall down to 600, 400, 200 over 4 days, although the patient doesn't have thrombocytopenia, that should make you worried because that's a significant fall. The other thing is ESR, which was very high, starts normalizing. So this is actually a false reassurance. The ESR is not better because the patient is better. That's because the patient is going on to a macrophage activation syndrome. The only thing that goes up dramatically is ferritin. From 5,000 suddenly becomes 25,000. You get a big jump. These patients also develop liver dysfunction, neurological dysfunction, coagulopathy, hypertriglyceridemia, which do not exist in patients with plain and simple systemic onset JIA. The confirmatory tested the bone marrow where you get erythrophagocytes, and these patients need absolutely urgent treatment with steroids and probably anti-IL-1 blockers like anakinra, which I know is a bone of contention in India because it's not yet available in India freely. So the bottom line is no diagnostic test in JIA. JIA is 100% a clinical diagnosis where it's important that we roll out alternate diagnosis, most notably infection and malignancy. Now, what is the role of autoantibodies in JIA? Rheumatoid factor, absolutely no role. I mean, I would say no significant diagnostic role. Most children with rheumatoid factor positive don't have JIA. And similarly, most children with JIA don't have positive rheumatoid factor. That's the most important thing to remember. It's a very poor screening tool. I get GPs write to me all the time saying that the autoantibody screen is negative. I don't know what it is. It is JIA because the autoantibody screen is expected to be negative. But it has got one important role, that's prognostic value. If these patients are very high rheumatoid factor, they have a risk of aggressive disease with early chance of erosion. So we need to be aggressive in escalating them in a timely manner. Anti-CCP antibodies actually are more specific than rheumatoid factor in predicting rheumatoid disease. Again, this is a classical example of a girl who has rheumatoid factor. Look at that wrist. Can you see that 8 carpal bones? No. They are all fused to become a composite mass. And this patient has got bony ankylosis because of she did not take methotrexate. She kept telling us she was taking methotrexate, and this is the mess she landed herself in. ANA and GIA again has no diagnostic value. It can be seen in up to 30 to 60% of non-systemic GIA. Again, what is the importance of ANA and GIA? It increases the risk of uveitis. So you need to be very diligent in referring this patient to ophthalmologists to make sure that these patients do not develop uveitis. Now, what are the primary goals of therapy in GIA? To eliminate active disease, to normalize joint function. When I break the diagnosis to my parents, they said, "Oh, it's a shame my son can't play football now." I said, "That's absolutely wrong. The whole idea of treating John or Matthew is to make sure that he can do whatever he wants to do in his life." So JIA diagnosis is no bar to physical activities. We just need to be careful when the diagnosis is made until he gets into remission. The other thing is to preserve normal growth and to prevent long-term damage. So what are the treatment principles? Number one, there is inflammation, switch off inflammation. First line, NSAIDs. May work in some, unlikely to work in most. So what are the best anti-inflammatories? We have steroids. Now we need to wisely choose. If the patient has got 25 active joints, I would prefer that give them 3 days of IV methylprednisolone. Whereas this patient has got an elbow, a knee, and ankle, I would much rather take him to theater and inject that with steroids, because you are actually delivering steroids to where you want it to work without much systemic side effects. So that is my preferred choice. The next phase, once you have switched off the inflammation, next is to keep inflammation switched off. And our first line is always low-dose methotrexate, which is tried and tested for 50 years now. We always prefer subcutaneous injections. We start folic acid with these patients. This is effective to prevent or manage uveitis as well. The important thing to remember is these patients, the commonest side effect is nausea and vomiting. And I took that slide away. So I had a teenager who texted our nurse saying that how methotrexate had made her life absolute hell. I know it works for my joints, but every morning I wake up dreading my next injection because it makes me sick. So we cannot really underplay the importance of a good history and asking for side effects. And that is a sign that tells that we need to move on. So another side effect we see is abnormal liver function in these patients, which may force us to sometimes stop methotrexate. And what do we give next? So we have got DMARDs like sulfasalazine, hydroxychloroquine, leflunomide, etc. But usually our preferred choice is biologic. Now, I can't make that claim for my pediatric rheumatology colleagues in India because there are significant financial constraints in obtaining biologic as a second line. So these are the list of biological agents we have at the moment. I'm not going to go through them in detail, but what determines the choice of biologic? It should be used only if methotrexate fails or if the patient is intolerant to methotrexate. Number two, usually anti-TNF is the first choice in non-systemic GIA. But what makes me decide what anti-TNF I choose? The first question is there a uveitis? Is there a chance of inflammatory bowel disease? In which case, etanercept should not be used. So our first line is, if the answer is no, you can choose any anti-TNF. If the answer is yes, we can only use infliximab or adalimumab. Now, adalimumab is given as 2 weekly injections, and which is probably the best anti-TNF we go today, because most people don't want to miss a day for infusions. If there are concerns regarding compliance, we may choose to go with an infection. If one fails, we can try the other. There is no harm in doing that. Now, that what has changed with, so these are some of the guidance for depending on the type of systemic onset GIA. I see some polyarticular patients with severe systemic inflammation, and anti-IL-6 is the best agent for them. Systemic onset, anti-IL-1 or anti-IL-6, and I can draw tocilizumab. If they are rheumatoid factor, you can use again rituximab or tocilizumab in these patients. One important precaution.
Few more slides.
Yeah, just a few more slides. Yeah.
Okay.
Important thing is that these patients need to rule out TB, which I think is more important in India than here. before we make sure we start them anti-TNF. The risk of flaring up latent TB is maximum in anti-TNF, but it can be there in other biologics as well. Again, we need to give infection advice if they get, for example, the patient is not chickenpox immune and they get chickenpox, we may have to give them acyclovir. And sometimes we may have to stop them for surgery because risk of infections. And more importantly, live vaccines are contraindicated in these patients. This is a comparative slide which I would like to skip. And this one slide about what is new in treatment. Now we have got biosimilars. Biosimilar is a molecule which is biochemically very similar to the originator biologic, but slightly different, but still has the same properties. But what is a big difference? Cost. The cost of adalimumab has come down by almost 50 times since the biosimilars have come. And my Indian colleagues say that biosimilars are available freely in India as well. And that's kind of changed the scene of biologics. It's easily available now. There are lots of new biologics that are coming in. And last but not the least, think about JAK inhibitors. Now, JAK inhibitors are molecules which work on this Janus kinase enzyme. But the biggest difference from biologic is that they can be taken orally. All the biologics are parenteral. So to have an oral biologic will make a world of a difference for children who are needle phobic. One question from parents: what is the risk of malignancy? There are studies say that there can be increased risk of lymphoma, but we use the BSPA statement. So when you looked at people who pre-biologic era, a lot of patients with uncontrolled inflammation had malignancy too. So when we compare the pre-biologic and post-biologic era, the eventual incidence of malignancy remained the same. So what we say is, although there is a subtle increase in risk of malignancy, if the patient doesn't get the treatment, has uncontrolled inflammation, that also increases the risk of malignancy. So at the end of the day, there is not a substantial increase in the risk of malignancies. This is the BSPA statement that I've quoted. One slide about uveitis, which is the commonest extra-articular manifestation. Two important points to remember. Uveitis can be asymptomatic but blinding, which is very important to early referral to this patient to ophthalmologists because they need slit lamp examination to look for cells in the eyes. Whereas enthesitis-led arthritis, uveitis is slightly different because if they are asymptomatic, they have a painful red eye. Prognosis. Rheumatoid factor positive poly and psoriatic GIA, they unfortunately have a low risk of growing out. We can put them in remission, but there's a good chance they may flare. Oligoarticular GIA have the best chance of growing out to this condition. Systemic onset GIA, some of them have a monocyclic systemic onset, they never have a problem. But people who are polycyclic, some of them remain systemic, whereas a good number of them become polyarticular GIA as they go along. Complications, joint damage. Again, if there is uncontrolled uveitis, they can get visual problems, growth retardation, both because of disease and treatment, immunosuppression complications, and obviously macrophage activation syndrome. Think about TMJ joint. Look at these people who have got micrognathia because of poorly treated TMJ arthritis. You can also get atlantoaxial subluxation. When they come with neck pain, we need to take an open mouth view to make sure they are not got atlantoaxial subluxation. I'll come to my last slide. Take home messages. Monoarthritis, it's very important to rule out infection or malignancy. If the patient has got systemic symptoms, especially weight loss, pain that wakes them up in the middle of the night, always think about malignancy. Reactive arthritis usually settles down before 6 weeks. What are the red flags in history? Night pain, joint pain that constantly wakes you up in the night, I would be worried about malignancy. Similarly, back pain in smaller children, I'll have a low threshold to do an MRI scan in this patient. A thorough systemic examination is important on top of the joint examination. Again, improving inflammatory markers can be a red herring in patients with systemic onset GIA. They may actually be going on to macrophage activation syndrome. So look at the patient in front of you than the laboratory investigations. And always think in rheumatology, common things are common. But if things are atypical, please ask your local pediatric rheumatologist. But as I said, I'm very thankful for this journey which started in Thrissur Medical College, then went on to Institute of Maternal and Child Health, Calicut Medical College, and then during my time in Great North Children's Hospital in Newcastle, and I ended up in my current home, Queen's Medical Center in Nottingham University Hospitals. Thank you very much, IAP, for once more giving me the chance. I'm happy to take a few questions, and thank you, everyone, once again.
Thank you, Kishore, for a very lucid presentation to very complex scenarios and the cases you have mentioned. I hope people have learned a lot. There is one question only, but I think I will also give Dr. Sani the platform to uh, do her comments on the whole talk and her share some of the experiences she had.
Thank you very much for that. And thank you so much, Kishore, for a wonderful discussion you gave us all about childhood arthritis. And I must say that rheumatology is actually the specialty of musculoskeletal medicine. That is to say, we are really looking at patients who can come to us with many diseases where the manifestation is predominantly in the joints and then in the connective tissue. And saying that, what we need to understand as we evaluate a patient is that every child requires a very detailed evaluation, and there are really no shortcuts. So, for example, if you don't take the history that this little 15-month-old male patient has an older brother who has a swollen joint, and this child slept very well and then woke up with one morning with a hugely swollen knee, you're likely to miss hemophilia in this patient. Similarly, if you don't take the history of a 6-year-old male again and try to understand that this child has got a failure to thrive and then presents with 2 swollen joints, you may be missing out on a common variable immunodeficiency. You can have a young 10-month-old girl who presents to you with severe pain when the baby is handled and has these hyperpigmented nodules near the joint, and that child could have systemic hyalinosis. You could have another patient who has got camptodactyly, and when you evaluate the child has actually got a rare syndrome called CSCP, and so on and so forth. So, you have to get a very detailed history, which gives you more than 80 to 85% of the diagnoses. 10% on examining that patient is the add-on, and just about 4 to 5% is the added value from doing all the fancy laboratory tests that you can think of. Certainly, there's no such thing as a panel of investigations that you want to do for any patient to diagnose juvenile arthritis because, as Kishore pointed out, there is no test that can rule in juvenile arthritis or that can rule out juvenile arthritis. Such that, for example, if my patient is rheumatoid factor positive, that patient would have tuberculosis. If my patient is anti-CCP positive, that could be a trisomy 21 with no disease. I could have a low titer ANA positive of 1 in 40 and have no risk of anything at all. So, all the investigations have to be taken contextually for the patient in front of you. So, not only are you going to take the history of a joint, but you want to find out what is the onset, what was the progress, and what is the current situation. In India, we are always challenged with tuberculosis in the back of our minds because we are a zone with so much of high endemic infection of TB that tuberculosis complicates our patients in many ways. When we use biologics, these children can develop TB because biologic doesn't allow the patient to generate a good granuloma so that this infection can disseminate. We also sometimes, even today, do see children with acute traumatic fever. We have to be cognizant about the weather change and what are the infections going around so that we can have many kids who come to us with chikungunya infection and a polyarthritis. So the kind of patients we tend to see in India are, I think, pretty much more challenging than what we see in the West because we actually are trying to wind our way through a river which is full of crocodiles and sharks, and we're trying to get to the bank on the other side. And these crocodiles and sharks are infections, infections, and more infections. And I think it's because of the milieu and the poor health and hygiene status in a nation of 1.4 billion where we have a lot more enthesitis related arthritis as compared to oligoarthritis. So it's absolutely tantalizing that in India, we see 30 to 40% of children with enthesitis related arthritis and up to 30% of children with systemic. And in the Western world, it's about 60% with oligoarticular disease. So these are different environments, they are different infections, different genetics, and certainly these can go ahead and alter the clinical presentation of these patients. And I also think it's rather naive for us to think that juvenile idiopathic arthritis has, one classification criteria, and then you have a control all delete button when the child turns 16 and suddenly they develop some adult onset disease. So really we have to move towards a classification system that is going to unify what children have as compared to what adults have. And probably the only thing different that we have in our little children is oligoarticular, ANA positive, early onset disease, where the children have a higher risk of being ANA positive. So I think it's challenging to do pediatric rheumatology in India. And one of the most vexing problems that we have is a patient who presents to us with fever. And in the presence of that fever, this patient has features of HLH, which is not uncommon in our intensive care areas. And you're aware that when a child with systemic arthritis presents for the first time with HLH or macrophage activation syndrome, then that's a diagnosis which is very challenging to make. And we today have a very exciting biomarker called interleukin 18. And it is said that there are cutoff serum levels available for IL-18 that can guide us and tell us that this underlying reason for the HLH is very likely to be a rheumatological condition, most likely systemic arthritis. And just to conclude, a last word on imaging. So I think it's the new age where ultrasound is used as a POCUS, as a point of care ultrasound. And for those of us who have it in the clinic, it's absolutely amazing to guide decision making. So for example, you can have a febrile patient who has no rashes, who has quotidian fevers, who has pro-inflammatory bloods, and you can't find any joint clinically, then go ahead and use your ultrasound probe. It's just like a stethoscope, and you may find very significant bicipital tenosynovitis. Or for example, you have a patient who presents to you with a single ankle that is swollen. When you do an ultrasound, you find that not only is it the tibio-talar joint, but it's the midfeet joints, it's the tendons around it. You know that this is complex disease and you are not going to treat it like a oligoarticular patient, that is to say a patient who has just the main ankle joint. So I think that ultrasound is coming up in a very big way, especially in Europe. I think much more in Europe as compared to mainland UK, and probably it really needs to become part of the training, and the youngsters coming up must learn how to use the ultrasound in their day-to-day practice. So I think with those few words, I think that Kishore did a great job. It's a very tough topic to handle, and that's what we spent the last 3 decades doing. So thank you.
Thank you, ma'am. Wonderful insight offered by you. And I can imagine the sharks and the crocodiles in India, which is obviously very complicated picture to deal with. And but I think Kishore is doing wonderful here, and he has come from India, so he knows he can balance the both, and he can do justice with our patients here. I will have just two questions here. The first one is a case put up by Stuti. 16-year-old boy presented with GI symptoms, loose stools, pain, and had bilateral knee joint swelling and pain on and off for last 4 weeks. Later, dorsum of ankle joint also gets swollen, but no redness, warmth. Had history of backache, MRI spine suggestive of sacroiliitis. ESR, CRP was raised, NT-CCP negative, on and off GI symptoms, no history of rash or uveitis. What is the diagnosis? Is it IBD associated arthritis?
So I can take that. So I think that IBD is a very important differential diagnosis here, and you can do a screening test in form of fecal calprotectin. If this patient has had a disease for over 4 weeks, you want to look at the serum albumin and see what that is doing. Often the albumin levels tend to fall, and it would be important to do an endoscopy on this patient to confirm exactly what is going on. So when patients have got inflammatory bowel disease, they have two types of presentation. They can have either axial involvement, that is the SI joint, or they may have peripheral disease. The peripheral disease often marches in the same direction as the gut inflammation, but the sacroiliac inflammation may have an independent flare up or activity or inactivity as compared to the gut. So yes, that's a possibility. The patient should be carefully evaluated.
Thank you, ma'am. Second question is, any development in the diagnosis of systemic onset JIA, and is there a role of naproxen therapeutic trial?
So Kishore, do you want to take
Yeah,
that?
yeah, I'm happy. Systemic onset JIA is very tricky because, as I said, you don't even need joint involvement to diagnose these patients. They essentially come as PUOs. But the fever pattern and the rash and the lymphadenopathy, hepatosplenomegaly, and the investigations always give us a clue. Now, if naproxen always used as first line in JIA, and you probably can use that in systemic onset GA, but the important message should be that it is the only type of sub JIA which needs only 2 weeks for diagnosis, because normally you say 6 weeks to make a diagnosis of JIA, but if you have 2 weeks of daily temperature, that is enough for you to make a diagnosis of systemic onset JIA, and we should have a very low threshold to escalate these patients to higher treatment from naproxen because of the risk of macrophage activation syndrome. So yeah, definitely naproxen has a role while we are incubating the diagnosis, but once the 2 weeks is up and we think it's a systemic onset GI, they need an absolutely early escalation of treatment with systemic corticosteroids and the first line and the next line treatment.
Okay, and just one last question from Shija. Does high LDH help to differentiate malignancy from other arthritis like JIA?
It may be helpful, but it's not definitive. So if I see a patient, so the boy I presented, who one presented with hip pain, he had an ESR of 100, CRP of 100, and his LDH was 4,000, which I would not expect with simple inflammation in JIA, unless this patient has got concomitant muscle disease, where we can get high LDH as well. But CK and other things are concomitantly elevated too. So if the patient has got very high ALDH, that may be helpful. But if you look at the patients with any patient with GIA or any patient with an ESR and CRP of 50 to 100, the LDH will be mildly elevated. So it is very difficult to say where do you draw a line as to what is significant and what is not. But if I see a disproportionately high LDH in a patient with joint problems, I would always be worried about malignancy. Madam may want to add more.
No, I totally agree with you. It's got to be a holistic view of the patient without taking any one investigation into consideration. So, for example, if your patient has got a mycoplasma infection and is hemolyzing, can have arthritis, can have an elevated LDH. So, there are many reasons for the LDH to go up, and it's basically suggesting to increase cell turnover, but you got to put it in the context of the patient in front of you.
Okay, so I think we'll stop here. And I would like to thank both of you for enlightening us with great insight and your knowledge of rheumatology. And I would like Dr. Atanu Bhadra to offer a vote of thanks to. Is he still around, I believe?
Yeah, Dr. Atanu, hello.
Yeah.
He's muted for some reason. He may be, I'm not sure. So, Jogesh, you want to take the honors and just conclude this session then?
Okay. So
He's
thank you.
muted. He's not there for some reason.
He's there, but I think he was there previously also.
Yeah, I saw him,
Yeah.
but
Okay. So, thank you, Dr. Bhiwan and Dr. Anand, for conducting very well with both our experts, Dr. Sujata Madam and Dr. Kishore Warrior, given the best whatever the rheumatology and the GIA. Yeah, Dr. Atanu, you want to say? Atanu,
No,
please.
continue, sir. Continue.
Okay. So thank you very much, both the experts and all the participants who join on this digital platform. And we are very eager to join again on the next month when the Bhiwan and the team is ready with the next topic. So thank you very much and good night, everyone. Good night.
Thank you so
Sorry,
much.
can I just word one more thing? Is Dr. S. Srinivasan on the call from
Yeah, sorry,
Chitmar?
already.
Yeah, he was my He was a wonderful teacher. He's taught me, and he was my DNB examiner in JIPMER
Thank
for
you, thank you,
25
thank you
years.
very
It's
much.
always a pleasure, Srinivasan sir, to see you.
Thank
Sir
you
It's
very
an
much.
absolute
Sir is
pleasure. Thank you.
always, he's the teachers of teacher, but he still say, I'm young learner every time.
Yeah, yeah. The
Sir is
learning is
always
never
with us
ending.
since more than this COVID
Today I
era.
learned so many points.
Yeah.
Atanuda, if you are here, any message for the team, for Pedicon, anything else you want to say before we conclude?
No, before that we'll meet I think twice we'll meet. So I think details will come there.
Okay,
Okay.
fine.
Still, he's preparing all the details.
Okay, I think it was a great learning session. We do this every 3 months, quarterly, and it is the first time that we have invited the IAP India team to our interesting town of Manchester and Oxford. They'll be visiting UK next month, and the Manchester program is on the 26th. I think the Oxford program is just so we will have a sort of a exchange of ideas. We are planning some collaboration and research. IAP UK is growing. We've just got a bank account. We've got about 35 members. So it is growing from where we started with the small inception of Dr. Atanu Bhadra, who always wants to stay in the background. He's not showing his face right now, but he probably started and brought this idea, and Dr. Ramesh, who first had this concept when we spoke about in 2021, just post-COVID. And it has grown now to include this immense collaboration, which is reaping a lot of fruits for and over borders collaboration. It is helping in recruitment. We are helping to get new recruits into the system who are getting trained in UK through this IAP collaboration and training in different centers in UK, and they're going back with more knowledge. I think this relation and this family is going to grow. So a very good evening from UK to all of you, and we will see you in November, most likely, with our next session for our this year's last series of webinars. And have a good evening in UK and a good night to all of you. Thank you, Anand. Thank you, Kishore. Thank you, Madam Sujata.
Thank you.
Yogesh. Thank you, Atanu. And thank you, Dr. Vasavraj and Dr. Neelam and all the stalwarts of my IAP UK friends who joined today.
Thank you so much.
Thank you.
Thank you,
Thank you,
Bjorn,
madam. Thank
for
you, everyone.
making our associate.
Good night.